Let's talk about imaging. Prostate cancer is well tracked by the use of PSA. The need for imaging is somewhat diminished, but whenever there's a clinical situation, PSA rise, new symptoms, fatigue, weight loss, minor pain, it's probably reasonable to re-image because you want to know the disease status. And you need to know whether the disease is bone dominant or non-bone dominant. You can give radium in the face of soft tissue disease, provided the lymph nodes are not overwhelmingly dominant. So if you have 6 centimeter lymph nodes and only 1 or 2 bone metastases, you may not want to give radium. You may want to focus on the chemotherapy because, of course, radium will not hit non-osseous metastatic disease. So I always, if I'm about to think about radium, I always image. I go, well, let's make certain that you don't have liver, lung, or large volume soft tissue lymph node disease. Small volume soft tissue disease is fine, but you got to watch it because during the time you're suppressing the bone disease with radium, the soft tissue disease may progress. That's why I prefer the therapeutic layering. I prefer to give radium for the bone and at the same time cover any soft tissue disease in the lymph nodes, for example, with either abiraterone or enzalutamide. For this particular patient, I probably would have given radium at the time that I started the abiraterone, because then when I give the radium along with the abiraterone, and if they have an abiraterone side effect, I will add the enzalutamide, and by the time I get to the point that enzalutamide is not working at about 6 to 7 months, then I'll be ready to go to chemo. Because now you're going, well, the enzalutamide's not really working, and what about soft tissue disease? Fortunately, in this case, there's no soft tissue disease, so you're allowed to go a little bit beyond the radium point at which I would start looking to end. In other words, after 6 cycles, and if the disease starts to progress, that's when I want to bring in chemotherapy or an alternative anti-androgen. Given the fact that the second anti-androgen benefit is quite short, and we learned that at ASCO 2017, 3 months. If you get the first anti-androgen, you may get 12, 15 months on average. That's the perfect time to give radium. What I do is, for example, if they get abiraterone, their PSA nicely falls, usually stays down for 7 or 8 months, and then you begin to see a little creeping up of the PSA. That's when I'll give the radium, right then, because I know that that abiraterone is going to fail, probably within 6 to 7 months. So I put in the radium right there. If I wait too long, then I've got to rely upon the second anti-androgen, such as enzalutamide in this case, and that is only going to give me 3 months. So you need to sort of play the chess game with the cancer. What is the cancer thinking? What is the cancer doing? What is its behavior going to be like? And you need those 6 months of radium to do the best you can for your patient with bone-dominant metastatic prostate cancer. So to summarize, bone metastatic disease is extremely common. 90 to 95% of patients with prostate cancer have bone metastases. That is the major single cause for morbidity and mortality in prostate cancer. Radium is the only directly cytotoxic agent which targets the bone and which can prevent bone pain, prevent reduction in quality of life, and which extends the life of the patient with bone-dominant metastatic prostate cancer.